If you're running a multi-specialty practice, you already know that your revenue cycle lives or dies right at the coding level. Every chart is either money in or money out. And when that moment of truth happens hundreds of times a day, the pressure on your back office is relentless. This graph tracks the national initial claim denial rate, and recent HFMA data shows it climbing to nearly 12%. That means roughly 1 in every 8 claims gets kicked back before you collect a single dollar. And looking at the broader trajectory on this chart, MDaudit found a 126% year-over-year spike specifically in outpatient coding-related denials, followed immediately by another 26% increase. Breaking down the industry impact, this chart shows that 41% of healthcare providers now report denial rates above the 10% mark. When nearly half the industry loses more than 1 in 10 submitted claims, those practices are dealing with a sustained structural revenue leak costing millions. It is tempting to blame this escalation on payer complexity or bad luck, but the data points somewhere else entirely. This infographic breaks down the actual top 3 drivers of coding-related denials: errors in diagnosis coding, modifier misuse, and insufficient documentation support. These are specific, preventable failures. They trigger automated kickbacks before a human at the payer level ever even looks at the claim. Even when minor coding errors don't trigger an immediate denial, they accumulate invisibly in the background. It often takes a massive payer audit years later to suddenly surface the compliance exposure you've been building up. Permanently fixing your denial rates requires more than building a larger appeals team to chase kicked-back claims. You have to move upstream and solve the problem exactly where it happens, at the point of coding. Solving this in-house is getting harder. There is currently a 12% nationwide talent gap for certified medical coders, creating fierce competition for a very limited pool of candidates. This chart shows the fully loaded cost of an in-house coder. Stacking base wage, benefits, and taxes, a generalist costs up to $75,000 annually. But multi-specialty encounters require advanced expertise. Hiring a multi-credentialed coder for that complexity pushes the annual cost above $81,000. That is just the cash outlay. Every new hire also brings a multi-week productivity lag while they learn your specific EMR workflows and practice protocols. Revenue slows down during that onboarding window. And once they are finally trained, a fixed headcount team leaves you operationally vulnerable during volume surges like flu season or open enrollment. When capacity is static, charts queue up. The traditional in-house model forces practices to overpay for underperformance while absorbing all the turnover risk. Imagine working through an ophthalmology modifier, then pivoting to complex cardiology documentation, and jumping into orthopedics. That rapid-fire context switching happens all afternoon. If you run a single specialty clinic doing basic evaluation and management visits, a generalist coder can comfortably handle the workload. But this diagram maps the overwhelming cognitive load of a multi-specialty coder. They have to memorize varying modifier rules, specific bundling edits, and unique payer contracts across dozens of entirely different clinical domains simultaneously. Well-intentioned generalists inevitably make specialty-specific mistakes in this environment, creating severe, long-term compliance and audit exposure. Multi-specialty coding has crossed a complexity threshold, where navigating requirements effectively requires distinct clinical domain expertise. This brings us to a strategic trade-off. To get that required accuracy, practices are choosing to give up physical HR oversight in exchange for specialized, credentialed precision and zero turnover risk. The modern solution is EMR native access. Your external partner works directly inside your existing software from day one, without clunky screen share workarounds. This split screen compares the workflows. On the left, a single in-house generalist attempts to process every chart. On the right, an outsourced model automatically routes incoming charts strictly to the specific domain experts for those clinical areas. Moving to this model delivers immediate compliance advantages. The vendor absorbs burden for HIPAA, SOC 2 protocols, and encrypted network security. It also provides a built-in scalability mechanism. You can instantly flex your external coding team up or down with just 30 days' notice to handle seasonal volume surges. You transfer the heavy risks of training, compliance, and seasonal backlogs entirely off your balance sheet.
Processing massive amounts of complex clinical data without hesitation requires a level of speed and precision that humans achieve only when supported by automated systems. AI-driven predictive routing can instantly identify the specialty profile of a chart and assign it to the exact human expert matched to that domain. On this workflow dashboard, automated audit flags act as a safety net.
They scan the document and surface potential modifier misuse or diagnosis gaps before the claim is ever submitted. AI alone is dangerous, though. You strictly need human, credentials experts to review those flags and validate the final nuances of complex medical encounters. Combining AI pattern recognition with human credentialed expertise allows practices to consistently drive error rates below 1%. This scorecard lays out the financial reality. A fully loaded in-house hire costs $75,000 a year, while an outsourced specialist runs just $399 a week, operating at a sub 1% error rate. This saves you $34,000 to $54,000 annually per seat. To be clear, if you run a single specialty, low-volume clinic, maintaining your current in-house generalist setup is still a practical choice. But for complex practices, resolving these operational bottlenecks brings a sense of calm, control, and restored financial predictability. If you manage a multi-specialty group drowning in denial rates above 5% and bleeding revenue to high labor costs, this is the solution. The onboarding structure is low risk. You start with a 14-day go-live, run a 30-day risk-free pilot, and transition to a month-to-month contract. Solving the multi-specialty coding crisis no longer requires impossible hiring efforts. It is a simple choice to adopt the right operational structure. Start your 14-day implementation at